All right. Hopefully everyone can see this. Welcome to the Miami Herald live Q&A. This is my apartment here in Miami Beach. I'm the healthcare reporter, Ben Conarck at the Miami Herald. Joining us today, we have Dr. Erin Kobetz. She's the professor of medicine and public health sciences. She is the lead researcher on a countywide antibody testing survey that's been very fascinating to watch unfold and has taught us a lot about the scope of coronavirus infection here in Miami-Dade County. She's our expert, so we want to get right to the questions so that you all can have access to her very smart brain. So let's move on and get to the first question. So Elaine Bloom from Miami Beach, she wanted to know if a person who is still COVID-19 positive can also be positive for antibodies, and is there such a thing as a non-transmissible COVID after a certain amount of time?
Okay, hi Elaine. Thanks for that question. So I've not ever heard about non-transmissible COVID. Um, and so I don't really know how to answer that. And so I'm sorry to not be the resource that Ben propped me up to be. Yes, a person who is COVID positive can potentially also be positive for antibodies. And sometimes you have people who are who test COVID positive with RT-PCR for an extended period of time, and then they still show negative serology. And so, one of the things that's really important to recognize when considering the COVID pandemic is that so much of what we know is evolving in real time. There's not a ton of precedent for our understanding, our collective understanding of this virus, how to necessarily mitigate risk, or even to make sense of some of the clinical data. So I'm sorry, it sounds like you're potentially in a very personally confusing situation, and I wish that I could offer more clarity, but we do see lots of variability in test results where somebody who is COVID positive doesn't show antibodies or doesn't show antibodies for a far greater time than would be expected.
Great. Okay, thank you. Can we get the next question up? Because I think it's kind of similar as far as, right. So, I mean, can we talk a little bit, Dr. Kobetz, David's question here is about different types of antibodies if you're currently fighting the virus versus those if you've had the virus a while ago. So I'm sure we're going to get into IgG versus IgM here.
Okay, so right now there are a number of available serology tests that identify whether somebody has developed antibodies for the novel coronavirus. And you may or may not know that there are hundreds of these tests, most of which have not been evaluated or approved by the FDA. And on May 4th, there was actually new guidance issued by the FDA around which specific test had met the criteria for approval. And more importantly, the FDA characterized serology test as a complex test, meaning that it requires the involvement of a CLIA certified laboratory to run and process the test. And so, when you're talking about these tests, most of the FDA tests examine the presence of an antibody known as IgG. And this is an antibody that is thought to occur after sort of during the late phase of infection, if you will. And the question about whether you're fighting the virus or whether you're immune to the virus, none of the antibody tests offer any real insight about long-term immunity. We don't know enough about that yet. And theoretically, an antibody known as IgM would give you some indication about whether you were earlier in the phase of infection. But I think much of the data that's come out recently suggests that tests reporting on IgM may not necessarily have the level of sensitivity and specificity that's required, and that the IgM in particular could be really sensitive to potential cross-reactivity. And so again, there's not a lot of clarity on some of these answers. And part of the challenge is that there's a lot of discussion in the press about antibody tests, and their clinical utility, I think, remains somewhat challenged. I think broadly, it's understood that where antibody testing has the greatest impact is in something like community surveillance, where you are using antibody testing as a way to identify the seroprevalence of infection that characterizes local impact beyond what is reported through testing sites alone.
Yeah. And the next question that's coming up here is actually, the second part of this, I don't think you'll be able to address, but you were kind of speaking to this in your previous answer about this question of immunity. Could you just kind of zoom out a little bit, Dr. Kobetz, and talk to us about what we do and don't know about immunity right now and how long it might take us to figure out?
So I think, everybody who has had COVID is really anxious about this notion of long-term immunity, and whether once exposed to COVID or experiencing COVID, if potentially you may never get the virus again. I'm not sure that we have the answer for that right now. Certainly not in the United States. There are definitely data coming out of China and South Korea that suggests that there are people who have tested positive for COVID in 2 discrete time points, and they are not able to differentiate whether that's a new infection or somehow some kind of re-emergent infection from the initial exposure. And so I don't think we understand that right now. The University of Miami does, and One Blood do have a convalescent plasma donation program. So people who have had COVID in the past can go on to the One Blood website and can figure out the criteria by which they may be eligible for donating plasma, which in some small case studies has been indicated as a potentially efficacious strategy for helping people who are sick recover from the severe symptomology that they may be experiencing related to the illness.
And that kind of goes right along with some of the other questions we have here along kind of what you were mentioning, Dr. Kobetz, about sensitivity and specificity. Is there a way, I know that you were distinguishing here between the clinical use of these tests and the population use of this population study use of these tests. So could you maybe talk about how these things matter in terms of the clinical level versus the population health level, and why one is more useful than the other?
So, I think that anytime you're using a test, whether it be for individual diagnosis or for the intent of diagnosing a community, you really want a test that's very sensitive and specific. So you want to minimize the number of false positives and false negatives such that you don't overestimate or underestimate the burden of disease. And so in the community surveillance study that we're doing, we're actually using now a test that was created by Roche. And that test has very high sensitivity and specificity. I think the specificity is right under 100 and the sensitivity is around 98%. And so using a test like that ensures that when we estimate the prevalence of infection, that we're able to do so with some degree of accuracy, because the test itself is able to appropriately identify people who have antibodies.
Right. And in that situation, Dr. Kobetz, it's more important to kind of account for false positives than false negatives, right? Because I guess your concern is skewing that number. And I know in your first few weeks of studies that you had estimated with some degree of certainty, somewhere around 6.5% of the county population having, that being an estimate of having these antibodies. The next question we have kind of is along these lines as well. And it's talking about, well, the first part I will handle, which is whether Florida is including antibody tests in their daily numbers. No, they're not. And we did check that. So those numbers are just PCR tests, diagnostic tests. But the second part about how accurate are the antibody tests if they have a big 50% error rate, I think it's worth maybe Dr. Kobetz getting into the different tests that are out there, because maybe the most common question we got, which we didn't put up on a screen, is where can I get an antibody test? And when is the government going to make this available? Right. Yeah.
Actually, I think the Miami Herald covered today that
yes, exactly. Yeah.
Department of Health testing sites across Miami-Dade County are going to be offering free antibody testing. And I read that article with great interest, because I thought, oh, how interesting that these tests are now going to be available, when I think that the CDC continues to question the potential legitimacy of using the test for any sort of clinical purpose. And so I need to know more about how the testing sites plan to use that information. I think the question that the last viewer was asking actually has to do with some of the criticism that came out from the Centers for Disease Control maybe a week or two ago, right, Ben? Where
Yep.
they were combining data from antibody testing and RT-PCR. And obviously that's not acceptable, because the data that we get from RT-PCR actually tells us who's infectious now. And arguably what antibody testing does is it sort of looks back in a snapshot of time, like in the past, and tells us who may have been exposed to the virus, whether symptomatic or not, on the basis of having antibody production. And so you should never, ever combine that data, not because it's potentially inaccurate, but because they're measuring very different things. And it starts to confound our understanding of what's actually happening and what public health practices may need to be put in place to mitigate any potential risk.
And just to clarify this point before we get to the next question here, it sounds, Dr. Kobetz, like you would tell someone who does go to the state testing site to get an antibody test that maybe they shouldn't put a whole lot of stock into that test. Like they wouldn't necessarily want to go running through a hospital ward without a mask after they've been told that they have a positive result for antibody, because like you had said, we don't really know what kind of protection those antibodies might hold if the test is accurate.
Right. So we don't know. I mean, test accuracy aside, we don't know whether a positive result confers long-term immunity, and whether having the presence of antibodies means that somebody is protected from future risk of the virus. I think that's the big unknown. What's interesting is antibody testing, as we're doing it now, is sort of a qualitative test. It's just telling you whether you have antibodies or you don't have antibodies. It's not quantifying the amount of antibodies in somebody's blood. And as a result of that lack of quantification, we really have no way to assess whether somebody has adequate amounts of antibodies that would provide longer term immunity, which I think is ultimately all of our shared concern and goal.
Exactly. This next question I actually thought was one of the more interesting questions we received, and I might expand on it, but this individual wanted to know what percentage of seniors over the age of 60 and 70 tested positive for antibodies. And I guess I'll add to that, I'm not sure if you have that data offhand, and I don't mean to put you on the spot, but did you notice anything maybe more broadly, Dr. Kobetz, about, I know that there were some pretty high levels of asymptomatic people who tested positive for the antibodies despite never really feeling sick. I know there's some research that is indicating that might be more prevalent in younger populations than older populations. But I also know I've spoken to people who've looked at nursing homes that had infections, and you had asymptomatic cases in nursing homes too. So do you have any sense, or have you read any research at this point about that kind of dichotomy between having antibodies and having symptoms and age?
So, I mean, I think that we know from multiple studies now, including the one that we did in Miami-Dade County, that, upwards of 50% of people who have antibodies never had any known symptoms for infection. And so that part I know. The part about what percentage of people who participated in our study were 60 to 70 and what percentage of them had antibodies, I don't know off the top of my head. And I probably could sort of start digging into my emails while I'm on the viewer with you and see if I can get some clarity. But I don't know the answer. And I don't for what it's worth, as we've been evaluating the data and looking at it by different sociodemographic groups across Miami-Dade County, I'm not sure that I saw anything that tipped me off to a greater antibody prevalence in people of certain ages. Got it.
Thank you. Before we get to the last question, if I can, I just kind of wanted to inject this in here. As a reporter, or maybe better said, as someone who spends too much time on Twitter, we've seen a lot of the discussion around these serology or serological surveys, Dr. Kobetz, about the implications of the fatality rate. I know when Mayor Carlos Jimenez spoke about it, he wasn't really trying to get into that. Is there anything we can say one way or another at this point about the fatality rate and how much stock we should be putting in, based off, obviously the more infections that we know we've missed, the less that infection fatality rate is. But
So yeah,
yeah.
I mean, I think that that's a really important question, and I think that is something that hopefully over time and more comprehensive data that will start to get to the bottom of, right? Where,
Hmm.
seeing there are some people who feel like the infection fatality rate is really inflated, and the reason being is because we don't have an appropriate denominator by which to sort of account for the number of people who actually had disease against the number of people who died from it. And I'm not sure that like we're there yet. I do think that there are complex like systems in place that allow us to track and monitor flu and influenza related deaths. And I do believe that like ultimately we're going to develop somewhat of a similar robust surveillance system for COVID that hopefully will allow us to better appreciate like the mortality risk associated with this particular infection. Again, like think about it, March 14th or I mean, that's when like my family started to like shelter in place was 3 months ago. And I
Yep.
know it's crazy because COVID time is not like normal time. I sometimes feel like days are like thousands of hours. I mean, there's no
Yep.
separation for me between like work and home. And
Right.
something that was like 2 months ago seems like it was 2 years ago. And the knowledge that we're gaining is really evolving in such a rapid fashion that it like confounds my expectations as a scientist because scholarship is often very protracted and slow and purposeful. And in a situation like this where people are in pain, like patience is a virtue, and so it needs to move with this level of rapidity. I think we're going to get that clarity, Ben. I just don't think it's going to be right now. And I do have a sense that just sort of looking at the data that's been reported from other countries, that it is likely that the fatality rate is somewhat inflated, but maybe not to the extent that all of us hope. Like, I think that for certain people, and we don't necessarily understand why, there is increased susceptibility both to COVID itself and also to severe, like a severity of infection once exposed.
It's worth just. I know we have one last question, but before we get there, I just think it's worth putting your study, Dr. Kovitz, and I should say study. You're the lead researcher, but there are other people involved, into context because, yeah. So when you all came out with your results, this was one of the first major serological population health studies in the country, and the results raised a lot of eyebrows at the time. Since then, we've seen a lot more serological surveys come in, and a lot of it's kind of falling into
Same
this kind
place.
of wheelhouse, right? Like 10 to
Oh, right? Like from
what's
across the globe, we're like starting to see like
exactly right.
consistency. I think, what happened, and I don't mean to like cut you off, but I think
No, go ahead.
what happened is that, the first, our study was arguably the second real big study that was occurring nationally. So the first was in Santa Clara, and their sampling strategy was very, very different than ours, where they basically worked through Facebook and other social media platforms to allow people who wanted to participate in the work to sort of self-identify as interested in participation. And so what we did was sort of turning that on its head a little bit, where we randomly selected participants from across the entire county, being extraordinarily mindful of the racial, ethnic, age, and gender distribution of the county, and trying to model that or represent that proportionally in the people who participated in our study. The reason we did random sampling is sometimes when you offer people the chance to participate, you end up getting the worried well, or people who say, hey, I really want to get an antibody test because I'm pretty sure in November I had an illness that sounds exactly like COVID. And if I have antibodies, then I have some sort of sense that, yes, in fact, I had this virus. And one, it makes me feel better about why I was so unbelievably sick. And two, maybe it gives me some sort of way to manage my anxiety about this scary new virus that none of us really understand or know what we would do with where we'd get sick. And so,
Right.
Ben, like, I know this is a very long-winded answer, but I think that's part of it is that, like, there was a Santa Clara study that showed it was around like 2%, maybe 1.5%. And then we came out and said, no, it's closer to like 6%. And I think people saw that difference and started to doubt the integrity of both of the findings. And now I think over time we've been somewhat validated that we were right on the money. And what we
Right.
were finding in Miami was really no different than was being reported for other parts of the world that were employing similar sampling strategies to estimate the seroprevalence of infection. And obviously, our rate is much lower than New York, but we also know that, like, geographically and demographically, and even in terms of sort of the organization of the city, that we're very different. Um, and so it's not
Could you talk?
surprising, I think, to many of us that that rate would be higher.
I mean, could you talk about the kind of the ramifications of that 6% number, beyond the what we were discussing about infection fatality rate? But I know there's something we can learn from that about herd immunity and how far away we might be from,
Really far
there's,
away.
yeah, yeah,
Um, so, in order to establish herd immunity, you have to be closer to 60%, and we're about 6% for now. What's interesting, and my son and I were talking about this earlier today, is did you see, like, the Sweden public health expert sort of recant on their decision
hmm
to sort of approach disease mitigation through a herd immunity orientation, where they really just were like, no, everybody do what you want, go about your normal lives, we'll be fine. And now they arguably have the highest death rate in the globe. And their lead epidemiologist is sort of saying, like, I'm sorry, I made a really big mistake because this wasn't the appropriate way to approach COVID, because it is a unique virus. And again, there are certain individuals who, for whatever reason, are extraordinarily susceptible to pretty severe outcomes.
right. All right, and then we're going to get to this last question after one more, I promise. Just what? Just because I think we're hovering around this idea of Dr. Kobetz. What do you think is the kind of the most meaningful conclusion you've drawn so far from this study? And is there anything that you're hoping to learn more about from this particular antibody study going forward?
So, I think the most meaningful conclusion that I learned is that there were a lot of people who had antibodies who were asymptomatic. And I do think that we were one of the first groups to start really quantifying the fact that there was a high proportion of individuals who theoretically were exposed to the virus who never knew about it because they were completely asymptomatic. And I think appreciating that is really important when you think about public health measures, which need to account for the fact that somebody could be infected and asymptomatic, and your exposure to them being asymptomatic doesn't confer that you will have the same sort of disease experience. I think the other thing that I've learned that's like sort of my silver lining, and I've said this in multiple media outlets, is that I don't know that I was fully prepared for the ability to work so effectively with the mayor's office and Florida Power and Light and Miami-Dade Fire Rescue and the police department, and how we all sort of came together, bringing our individual expertise and resources to the table. And it was through this collective marriage that we were able to accomplish something that's pretty profound. And if it weren't for COVID, I'm not sure that all of us would have had the same willingness to work towards a common purpose. I'm also incredibly inspired by the number of students at the University of Miami who decided to volunteer, to immerse themselves in a real public health emergency and to commit their skills um, to what we were trying to accomplish. And I remain really inspired by their volunteerism and learning with them and from them as they interface with participants across Miami-Dade County, and are probably better suited than I am to speak to many of the reservations that community members bring to us about the potential risk of participation.
Yeah, it's worth noting that has a very strong public health program, and that we are benefiting from that right now, as you can see with Dr. Kobetz. We'll get to our last question because we don't want to keep you longer than we have to. So this part we're going to skip over if that's okay, Pierre, because we've kind of touched on this already. But there's a second part here where we're asking about is this kind of question. If I suspected I had this disease in January, how could I go about accessing the tests? And I think we kind of have already touched on this.
But here's my 2 cents.
Right.
So you could go to the testing site and you could get a test for antibodies and you could be negative. Does that mean that you didn't have the virus in January? Maybe not. You could go to the testing site and test positive for antibodies. And that doesn't necessarily mean that when you were sick in January that you had COVID, because it could have very well meant that you were exposed to COVID at another point and asymptomatic, and that's what's driving the positive antibody results. And so we don't, trust me, these tests are not going to give you that answer, not with the degree of certainty that I think people are reasonably seeking.
Well, we really appreciate you spending half an hour with us. Dr. Kobetz is very busy, but she always makes time, and we really appreciate her. Thank you so much, Dr.
Thank you, guys. It's really a pleasure to speak to you all today, and I hope that I've helped shed some light on your burning questions about COVID and antibody testing, and want you to know that I do believe very strongly that science will not fail us, and we will have more answers and vaccines and treatments, and we will get through this together.
I love ending on a positive note. That was great. All right. Thank you so much, Dr. Kobetz, and thanks everyone for joining us, and hope to see you next time. Thanks a lot.